I have the pleasure of introducing. Can you hear me, Patrick?
Yeah, it just prompted you that the meeting is recording.
Oh, okay. Okay, perfect. Okay, again, it's my pleasure to introduce Dr. Halkar, who is going to be talking to us about prevention in peripheral arterial disease today. Dr. Halkar is a senior associate consultant in the Division of General Internal Medicine and is a fellowship trained in vascular medicine and preventive cardiology from Mayo Clinic Rochester. Prior to that, she worked at Mayo Clinic Rochester as a hospitalist for 1 year. She also works as a hospitalist at the Cleveland Clinic and as a cardiology hospitalist at MedStar Washington Hospital Center in Washington, D.C. Dr. Halkar completed a postdoctoral certificate program in clinical and translational science research during her fellowship training. She was recently awarded the RACER Research Grant through 2021, and she is working on a study looking at well-being amongst post-MI patients undergoing cardiac rehab. She is also board certified in clinical lipidology. Dr. Halkar, the floor is yours, and thank you very, very much for your time and for teaching us today.
Well, Sheikh, thank you so much for the opportunity to present today and share a little bit of my knowledge. Hopefully that adds a little bit of what to your knowledge, and we can move the practice of PAD forward. So I really appreciate the opportunity, and without further ado, I'm going to share my screen and my presentation here. I'm going to go into the screen mode. So is this okay, a view for everyone?
Perfect.
Okay.
Yeah.
Thank you. So I decided, when I was asked to pick the topic, I decided what should I talk about, and my favorite topic is peripheral arterial disease. And every time I look it up, I feel like, and as I see in practice, I feel like there's still some gaps. There's still, it's like a little stepchild, and we still need more attention for peripheral arterial disease. So that's how I came about the decision to present on PAD and try to see what we can do even within the cardiology world in our practice to make care for PAD patients better discovered and executed. So that's where this talk is coming from. I have no disclosures. So my objectives for today are basically little more knowledge on recognizing the prevalence and indications to screen PAD, understand and apply optimal medical management for these patients, and also try to assess and treat it as a polyvascular atherosclerosis involving all the vascular beds, and keeping in mind that someone who's your coronary patient, obviously has atherosclerosis in other beds, and approaching the medical management in such a manner. So peripheral arterial disease, when we think about it, broadly obviously encompasses vaso-occlusive disease outside the coronary beds. And today we'll be focusing mainly on the lower extremity atherosclerotic vascular disease. And if we, review the epidemiology of PAD, following coronary artery disease and stroke, it's actually the third most common cause of atherosclerotic cardiovascular disease. And there's about more than 200 million people worldwide, and in America alone, 8.5 million Americans are estimated to have peripheral arterial disease. Oh, sorry, I don't know what I did. So there was a nice review paper that looked at a 10-year course of trends in, epidemiology, and it showed that it was a global study, which showed that there was a rise in PAD by 29% in the low and middle-income countries, not that low, about 13% also in the high-income countries. And they looked at the burden of all kinds of atherosclerotic vascular disease. And obviously, when this was a PAD-related paper that focused on PAD, but the growth was much higher for peripheral arterial disease as compared to coronary artery disease, which could have been explained by, okay, maybe there was more awareness, maybe more people were getting diagnosed now with PAD. So obviously with age, you have an increased prevalence. And if you look at more than 70-year-old, the geriatric sort of patient population, 1 in 7, you'd not be surprised, have PAD, with a higher incidence of, symptomatic and severe disease in men. And if you look at races, then African Americans have more prevalence of PAD compared to the white population. And where does it stand in terms of being? I'm sorry. Oh, So it's
excuse me, Patrick, please make sure everybody is muted, and please everybody try to mute for background noise reduction. Thank you. Sorry about that.
No, you're fine. So PAD is a strong predictor of systemic atherothrombotic events and all-cause mortality, cardiovascular death, MI, and stroke, as compared to other factors too. So in order to make this a little more interactive, you can think the answer to yourself, but I'd like to start off with a case. And my first patient is a 64-year-old Caucasian female seen by, since it's residency season, a new intern in your clinic for pain in her legs, right more than left with walking, along with intermittent joint pains. And the walking distance is variable, and the time to subside varies after she stops walking, and the pain may last a few hours. She has no prior medical diagnoses. She's not on any medications, negative family history. She's a smoker, drinks about 1 to 2 drinks a month. So pretty, healthy living. Activity level, she's active by way of her day-to-day life, cleaning the house, vacuuming, which for her is pretty good, meeting 4 meds. And lately she has pain in the legs. She's a vegetarian, and vitals are okay. Physical exam is unremarkable. And the intern tells you he only checked the radial pulse, and he came back to kind of give you the H&P summary there. So what would you do to work up her exertional leg pain, which she's talking about, sounds like claudication? Would you think like a full body vascular exam would suffice? Would you want to order a resting ABI assessment? Would you want to order both? Or would you just want to put her through an exercise ABI assessment? I'm sure everyone knows the answer to this, but I'll wait about a few seconds here for you to think about the answer, whether you'd order a resting ABI, an exercise ABI. Obviously, we know you'll do a full body vascular exam. So I'd like to start with the approach to this question by highlighting the fact that, majority of the patients with PAD actually have asymptomatic PAD or have atypical leg pains. Like our lady said, I don't know, the walking distance is kind of variable. The claudication itself happens in 10 to 30% of PAD patients. So most of them present with atypical leg discomfort, and their awareness also is not that good of what exactly this discomfort could be from. Could it be joint related, muscle related? I don't know what it's coming from. So they're not too descriptive about it. Obviously, the physical exam can vary anywhere from, you might have a pulse exam that's normal or suboptimal, but if the pulse exam is very subjective, how you grade the pulses when you do your physical exam, you may or may not have vascular bruise. Obviously, in advanced stages, you're going to have a non-healing wound or gangrene, and findings of elevation, pallor, and dependent rubor. So obviously the initial assessment for the last guidelines, and I know they're working on the new guidelines now, but a physical exam is a must for everyone, a full body vascular exam from head to toe. And what about the ABI? Where do we stand and, on the ABI recommendations? So I just decided to look at both the guidelines across the Atlantic here. And if you look at the AHA, ACC guidelines, as well as the European Society guidelines, they are pretty consistent that they do recommend ABI assessment, which is like a routine resting ABI assessment in those with increased risk of PAD. And that would include the age more than 65, people who have atherosclerotic vascular disease and other vascular beds, or those diabetics who are actually at a younger age, less than 50, with diabetes and one additional risk factor. Obviously, your tobacco abuse will, count towards an earlier diagnosis for PAD here with an ABI. And also those with between 50 and 64 with other risk factors for atherosclerosis or family history. And the European guidelines do concur with this. So those who have findings in the history and physical definitely recommend a resting ABI for that. And in addition, they also highlight those undergoing CABG and those with heart failure. They give them a class 2 indication for ABI assessment. So we do have a little bit of a difference in ABI assessment when we look at Mayo Clinic criteria with other institutions. not a whole lot different, but we do classify anything between, we know that I don't need to explain to this audience that ABI is higher of the ankle pressures and higher of the arm pressures. This is probably a slide more for an internal medicine audience, but the difference I want to highlight here is the Mayo Clinic criteria and other institutions. I think we get a little more stricter, I would say, because below 0.5 is what we consider severe. And, although it's not a whole lot difference, it does definitely, when people come with ABIs from other institutions, we kind of reclassify them just a little bit at Mayo. So this lady of ours had this ABI done. And as you see, starting at the superficial femoral here on the right, she did have, her ABI was like 0.53 at the posterior tibial, consistent with moderate disease at least. But at the dorsalis pedis, with the waveforms, you would think that she have a little more than moderate disease, but this is a resting ABI. And so who knows, if we did do a post-exercise ABI, it might have dropped into the severe category on the right. And a little bit of outflow disease there, borderline on the left. So that was her. So basically, it was good that we did an ABI on her when she came to our clinic. But if you look at data out there on diagnosis of PAD, there is a lack of awareness both amongst patients as well as physicians, mainly primary care and, physicians who don't see atherosclerotic patients on a routine day-to-day basis. And in 2006, a survey indicated that only 25 patients of the general public was actually, who did the survey, was actually familiar with PAD. Obviously, the awareness for stroke and myocardial infarction is much more. Only 50% are aware of what are the risk factors, that the risk factors are similar to someone with, a stroke and a heart attack. And 14% are aware of, that PAD can lead to amputation and death as a part of PAD complications. So there's much more to do in terms of public education on, if you do have symptoms with leg pain, don't wait too long on it, because then disease progresses if they don't seek medical attention. And obviously, amongst the physicians, this was like more in the primary care offices. Only 49% of the PCPs were aware that their patients even had PAD. And when they did a survey of orthopedic and podiatry referrals, 20% of those referred to orthopedics and podiatry for leg pain assessment had occult PAD diagnosed when those subspecialists did, assessments. And patients with PAD are less likely to receive optimal medical therapy compared to patients with coronary atherosclerosis or stroke. As far as statin use, you see it's only 59% in the PAD subgroup compared to the coronary, and antiplatelet is also actually quite low compared to the coronary patients. So follow-up question to our patient, she has hyperlipidemia, LDL is at 142, rest of the labs are unremarkable, triglycerides a little elevated as well. What do you do next? Aspirin, statin, supervised exercise therapy, or all of the above? And I'm sure most of you are thinking all of the above, which I think would be the correct answer. Sorry. So antiplatelet therapy, again, I like to compare both the guidelines. And the reason I looked at this a little bit more in detail was the American guidelines say either aspirin or clopidogrel is fine, class 1 indication. And, the European guidelines say long-term single antiplatelet therapy, but they do go ahead deeper into it based on the results of the Capri trial and say that for patients requiring antiplatelet therapy, they give a class 2 indication for clopidogrel preferred over aspirin, whereas we don't really favor one or the other in the United States here. And what about those asymptomatic patients who have PAD? Would you, let's say someone came to you with just for screening, and because of their history and risk factors, you went ahead and did an ABI, and you found PAD, but they're asymptomatic. Would you really put them on antiplatelet? And I think I like the American recommendation here that in asymptomatic patients, when you look at those with ABI of less than 0.9, antiplatelet therapy is reasonable, although it's a class 2A indication. I think that's good. That's a good guidance right there. And those with a borderline ABI of 0.91 to 99, it's a little more, uncertain there. The Europeans really don't find any benefit. And this recommendation of not giving antiplatelet therapy in the European guidelines was based on certain studies. You might have heard of POPAD, and there was another study by Fuchs and group. These were studies that basically included a lot more people with ABIs in this category above the 0.9 incidentally discovered borderline category of PAD. So definitely they didn't see that much of a benefit, and that's how they gave that recommendation. But I like the split up here of the ABI for the antiplatelet therapy. So talking about the Capri trial, we all know that, the Capri trial was multi-center randomized double-blind trial, and it looked at different subgroups of atherosclerotic vascular disease, stroke MI, and symptomatic PAD. And symptomatic PAD in the Capri trial was defined by an ABI of less than 0.85. With intermittent claudication, and they might have had a prior revascularization as well. So amongst the 19,000 patients that were randomized to clopidogrel and aspirin, the primary composite endpoint was a 3-point composite of stroke, MI, and vascular death. And as you see here, the mean age was around 62, 72% were male, 95% white, mean follow-up of 2 years, and clopidogrel was definitely better overall. But if you look at the PAD subgroup, clopidogrel was significantly, forest plot here, much better in terms of the average event rate. Here, relative risk reduction was about 23.8%. So that ESC recommendation of given the class 2A, maybe favor clopidogrel over aspirin depending on your patient and the individual bleeding risk profile. I think this is good evidence right there. Now, then came along ticagrelor, right? So EUCLID was another study that looked at patients with symptomatic PAD, again defined as the little more lower ABI here, 0.8 or below at visit 1, or 0.85 or below, or prior revascularization. Randomized to clopidogrel or ticagrelor 90 BID. It was a 14-month 26-month follow-up, 14-month recruitment. Again, 3-point composite primary endpoint, and TIMI major bleeding was the safety endpoint there. Similar mean age, 73% male. No differences were noted in the primary efficacy endpoint, acute limb ischemia or major bleeding. But when you looked at those subgroups that were enrolled based on prior revascularization compared to those enrolled by prior ABI criteria, obviously those were sicker patients who had had revascularization in the past, and they were noted to have higher acute limb ischemia and myocardial infarction. So basically, the event rate was higher in that sicker population, but the old trial itself did not find a great benefit of ticagrelor versus clopidogrel. So coming to the point that PAD...
Can I ask a question, or do you want to wait until the end?
Oh, you could, yeah.
Where does the role of, I'm sorry, I'm Brent Fideau, and thank you, I'm enjoying your discussion. Where does the role of a calcium score and using, I mean, coronary CT is so ubiquitous, but let's say we have a very low calcium score, we're seeing a patient, we're applying the MESA database and 10-year risk calculator, and their 10-year risk comes out to be less than 5%, but they have an ABI of below 0.9. I don't know. I guess you're looking at studies that were before we use calcium score, and I'm wondering if that helps stratify further the risk, the benefit of aspirin in these patients, or clopidogrel.
I agree with you on that, and I actually have some more slides on the later guidelines that have come out to help make that decision, because in 2018, as you know, PAD was classified as a major risk factor, and we'll look at this in a bit, if you don't mind me continuing, and then we'll come back to the question.
Yes.
Perfect. So, to highlight the fact that polyvascular disease, your patients have polyvascular disease. And if you look at, let's say you have a patient only with PAD as a diagnosis, you think about this patient, these PAD patients, 61% of the PAD patients either have coronary or cerebrovascular disease going on in their, vascular beds. And this is data from the REACH registry. So with polyvascular disease, those who have PAD and coronary obviously have worse outcomes here, at 3 years. This data is from EUCLID as well as the PEGASUS TIMI 54 trial. You see a big difference there between PAD alone and then polyvascular disease there. So definitely we need to keep in mind those with more is worse in terms of atherosclerosis. So we all know this, and I'm not going to spend too much time on slides that you're aware of. Statins for all, we have data from the protection study, which was an old study, and then asymptomatic PAD also, statins improved cardiovascular outcomes. There is data out there on that, and they've also actually had some association with improved pain-free walking time, and these are smaller studies that are listed at the bottom of the slide right there. So here is the slide, Dr. Brent, on PAD as a major ASCVD event. So in 2018, when the guidelines came out, it was really good to know that they added symptomatic PAD, history of claudication, ABI less than 0.85, or prior revascularization or amputation. So the little bit more severe sort of not severe, but I mean mild to moderate, but or prior revascularization would be more severe disease as a major ASCVD event, and along with ACS, MI, and stroke, which was a good thing because this helps us decide right here. And we'll talk more about the risk stratification, but the next slide here shows you that a very high-risk patient on the right side here is 2 major events or 1 major event with multiple high-risk conditions. So I just want to go back real quick to that slide right there. So if you have either ACS, MI, stroke, or PAD, 2 of these, or even 1 of these, and more than 2 high-risk conditions, such as heterozygous FH, prior CABG outside of the ASCVD event, diabetes, hypertension, smoking, persistently elevated congestive heart failure, or age greater than 65, it does up stratify you to a higher risk category. Now, the patient that you were referring to, who has a little bit of calcium on the CT scan, a less than 5% or 5% risk on their MESA with the calcium, I'm presuming. And I think you mentioned the ABI was in the borderline category of 0.9
right.
below. Is that right?
Yes, correct.
So what are you supposed to do? Do you put them on antiplatelet or statin? I'd say I personally would look at, was that ABI done for screening alone, or was that done for symptoms, which would guide me right there? And I'm presuming you're talking about the screening category.
Correct.
Yes. So with the screening category, as if you recall a few slides before, the AHA guidelines have it as those that have an ABI of 0.91 to 99, it's actually your call right there. But anyone below 0.9, I personally, according to the 2A recommendation, would maybe tell the patient, hey, you may benefit from an antiplatelet, because that this, no matter what they do, disease is going to progress over time. And so that's where we got to probably individualize the decision based on a discussion with the patient and their preference. This is what I think, and anybody else has any thoughts, we can probably discuss this right now. What are your thoughts on that, Dr. Brett?
I understand, and I agree with you. One other thought, I'm just asking because it's been in our journal a lot lately. Fatty liver disease, we all see steatohepatitis.
Yes.
It's in 25% of patients. It's a marker of inflammation, and I'm reading that they have inflammatory markers that are elevated biomarkers. Should we be considering that a risk factor along with some of the other ones you're talking about?
Yeah, so even though it's not spelled out in the guidelines yet, in the practice that, and in reviewing the literature on steatohepatitis, these people are the patients who benefit from statin therapy regardless of, having systemic atherosclerosis stenotic vascular disease only in terms of their liver disease and inflammatory risk condition itself. So I personally, what I do is when I see patients with steatohepatitis, I strongly recommend statin therapy right there. I don't know about antiplatelet. I don't necessarily do that, but statins I definitely do.
Thank you.
Yeah, thank you. So just moving on, so should we aim for a target LDL in these patients? The way we should approach this is, I think, obviously, like we always do, achieve a 50% reduction first, and then if the LDL remains more than 70 on maximally tolerated statin therapy, adding ezetimibe may be reasonable. Again, this is based on where does your patient fall in that risk profile. Is he a very high-risk patient, or is he someone, who is not that high risk and you're okay with an LDL less than 100, but obviously I'd want it less than 100. So why am I saying lower the better in LDL? So if we kind of recap on the FOURIER trial and we look at the PAD subgroup, we know that FOURIER was a double-blind randomized controlled trial looking at evolocumab versus placebo in 27,000 plus patients with ASCVD on statin therapy, mean follow-up of 2.2 years. This also defined PAD as ABI less than 0.85 with intermittent claudication or prior revascularization. Primary endpoint was a 5-point composite: death, MI, stroke, hospital admission for unstable angina, or coronary revascularization. Out of those 27,000 plus patients, not a lot, but 13.2% had PAD. And, again, this is another subgroup that had no prior MI or stroke within the PAD. So you see that almost 50+%, as we outlined earlier, always have some other atherosclerosis somewhere. So now these are the primary and secondary endpoints. The primary endpoint is on your left here, secondary endpoint on your right. So the primary endpoint was a 5-point composite. The orange is the PAD patients, and the black here is the without the PAD for both these graphs. And you see that the event rate is much more in terms of, if you look at the PAD patients versus the no PAD patients. And the curves, split pretty early here, 180 days, actually less 90 days from randomization. And so you know that PAD does carry a significant prognostic risk here in itself. And if you look at major adverse cardiovascular events like cardiovascular disease, MI, or cardiovascular death, MI, or stroke, by PAD with polyvascular disease, the red group, PAD without vascular disease in other beds, and the MI or stroke without PAD patients. You see those with PAD and polyvascular are the worst in terms of MACE. And again, the PAD without other beds is also worse than just the MI stroke patients. So this is all data from FOURIER for you. And what about the benefit with evolocumab? Let's focus on the graph here on the left with the primary endpoint. And the red is the evolocumab, the blue is the placebo. And the arrow is pointing towards a reduction in the primary endpoint. So amongst the PAD patients, there was a 3.5% absolute risk reduction, as opposed to the 1.6% absolute risk reduction in those without PAD. So greater benefit was derived in those with PAD, both in terms of the primary endpoint, as well as the 3-point composite of CV, death, MI, or stroke, similarly. So that's why I'm saying, look at the data even more. When they looked at overall major adverse limb events in all the patients, evolocumab did reduce the limb events right there. And when you looked at adverse cardiac or limb events, the patients with PAD, again, derived more benefit as compared to those without PAD. And this is the reason why I feel like less than 70 might be better, because FOURIER data do indicate lower the LDL, better the outcome overall. So that lady that we now put her on aspirin and statin, she probably does not want to come to your cardiac rehab or, for supervised exercise therapy. So what is the role of supervised exercise therapy? We do have data, as we all know, to back up the improvement in functional status, quality of life, and reduction in symptoms overall. So it is a class 1A recommendation, and it should be discussed as a treatment, option for a few months before possible revascularization, because they are going to ask you, can I have a stent, or can I, get something done for my PAD with so much disease? And the CLEVER trial was a small trial, but compared to optimal medical treatment and optimal medical treatment and supervised therapy, or optimal medical treatment with stent revascularization, both the stent and the supervised therapy group had good peak walking time improvement at 18 months compared to the optimal medical group. And there was also a greater improvement in claudication onset time for those who exercised, versus the optimal medical group. The stent did not really have any impact on the claudication onset time, although it improved the quality of life for some reason. And then we had the ERASE trial, another small trial of a few hundred patients that, when you do both revascularize them and give them exercise therapy, it's better maximum walking time and just the health-related quality of life scores. So revascularization and exercise therapy definitely works better than either or alone. And in May 2017, as you're aware, when your patient refuses to come for sessions, if they're living close to the hospital, we need to tell them that if they are, Medicare, then it's covered for them. 36 sessions over a 12-week period will be covered. And after that, if the physician orders it, then they're able to cover another additional 36 sessions. But what if they absolutely refuse to come to you for, exercise program? Obviously, you have to guide them and try to have your rehab people work with them remotely. Now, especially with COVID, this might be more important, that even a structured home-based exercise program does improve their conditioning and ability, walking ability and function status. And there's actually interesting data out there that even upper body ergometry, cycling, and low intensity walking has some benefit. And I think personally that this is from some physical cardiorespiratory conditioning that they're getting the benefit, and not necessarily that they're getting only lower limb benefits. So I think their endurance just improves with any form of physical activity. And from my clinic and talking to my patients, I have often seen that when you ask them, how much are you walking, what are you doing, they're just not motivated to walk because of the pain. And I think this is where the behavioral aspect of, remote interventions with phone calls or some point of contact person who kind of encourages you to keep up with the walking so that the walking distance is, improved, is very important. So this gentleman might be more exciting for the rest of the talk. So he's a 78-year-old male with typical polyvascular disease. He has a history of coronary disease, MI in 2000, 4 stents. He has HFpEF, hypertension, hyperlipidemia, type 2 diabetic. He's got a carotid endarterectomy in the past, and he has PAD with the right femoral artery stent in the past. His main complaints to you are he's short of breath, and he also has pain in his legs while walking less than a block. Denies any chest pain. He has tried the Canadian walking program, but his breathing precludes his activity level. He's on all the right medications right there. And vitals are okay. He has JVP. So he's got some fluid overload on your physical exam. Some edema and venous stasis there. Pulses, he's got non-palpable distal lower extremity pulses, poor pulse exam there. And so you send him for an ultrasound because you want to look at the patency of the stent. But you look at his labs, his LDL is right at goal, 63, right? So you're already below 70. His HDL is fair enough. Got a little bit of chronic kidney disease there. A1C is not that bad, and recent ischemic eval was okay. So he had a ABI as well as a duplex done. His ABI shows non-compressible vessels bilaterally, and not able to calculate the ABI basically, and inflow and outflow disease bilaterally there. So now you're wondering, what does the stent look like? Is he occluded his stent, or what's going on? And just remember that he was a guy who was on aspirin alone and statin and beta blockers. So he was not on dual antiplatelet therapy. So you look at his ultrasound and it says that the stent is okay, and there's distal reconstitution of the SFA, and the popliteal on the right is also occluded, but the left stent is occluded, but there's distal reconstitution of the SFA, and the right popliteal is occluded. So you do have reconstitution, even though your stent is occluded, and this gentleman is unable to walk, but he has heart failure and, so many things going on. So you want to improve his quality of life. So while you optimize his diuretics and everything, what are you thinking of doing for his PAD if he were not to have volume overload? Or let's say he has volume overload anyway. So he's not amenable to any intervention. Let's say he's not, the interventionalists in this group may say, well, you could still do something with that occlusion. But let's say you think that he's not amenable to an intervention. And in addition to telling him to stop smoking, how can you optimize his medical management for the claudication? Do you want to add a second antiplatelet? Do you want to increase his statin further? Do you want to add Xarelto, or do you want to start cilostazol? And I think I want to pause right here to get some thoughts from the group before I move on. Any thoughts from anyone?
Well, I think in light of the data that I've seen recently on Xarelto, I would be inclined to consider adding Xarelto.
Okay, as opposed to a second antiplatelet.
Correct.
Okay. No, I think that's a great choice. And obviously everyone in this group, nobody would pick D because of his heart failure. So let's have a look. So obviously cilostazol, I just want to highlight before we go on to the other part of the discussion, is that it is effective, but honestly, like, I have not seen it being used in my training, in my practice, and I've just not seen it being used much in the past few years. And obviously in this patient's contraindicated with his heart failure, although it does have data to improve walking distance and claudication, but we have newer drugs now, I guess. So let's talk about dual antiplatelet therapy first amongst the PAD patients. So the effectiveness got a class 2B in the ACCIAHA guidelines, and they said it was not well established. They looked at data from Charisma, PEGASUS, TIMI, and the VOYAGER trial as well. We all know that, these were not that positive, and the Charisma was not that positive, and then the PEGASUS TIMI and the TRA2P TIMI 50 showed increased bleeding. So really, these agents didn't get favorable scores on the guideline. So what was PEGASUS TIMI 54? More than 21,000 patients were randomized to 2 different doses of ticagrelor, 90 BID and 60 BID versus placebo. Everybody was on background low-dose aspirin. Amongst those 21,000 plus patients, about 5% had known PAD. The composite was a 3-point CV, death, MI, and stroke, and safety was TIMI major bleeding. So in the placebo arm, those with PAD, obviously sicker patients had higher rates of MACE, acute limb ischemia, and higher rates of peripheral revascularization procedures done. And, ticagrelor in both the doses reduced the risk of MALE. It did reduce the risk of major adverse limb events amongst the patients with PAD, and it was significantly lower. However, the major bleeding was higher compared to, the placebo arm, and the rates of intracranial hemorrhage and fatal bleeding, however, were not that significant. But the TIMI major bleeding of that, of more than 5-gram hemoglobin drop or 50% drop in hematocrit was observed, and probably that just led to the back off of not adding it. Going to COMPASS that we just highlighted a few minutes ago, just to recap, more than 27,000 patients with stable coronary artery disease, and I looked at the criteria of COMPASS. They actually recruited patients who had MI as old as 20 years ago. So these were actually stable patients with coronary artery disease. And there was about 7,500 patients with symptomatic PAD and polyvascular disease in there, randomized to 2.5 BID plus aspirin of rivaroxaban or 5 BID dosing or aspirin alone with a 3-point composite primary endpoint. And in the final analysis, we had about 6,391 PAD patients, 128 experienced major adverse limb events. And when we looked at the data here, obviously we know that 2.5 BID, the low dose rivaroxaban and aspirin, was really very impressive in terms of the incidence of nail reduction by 43%, amputations by 58%, peripheral vascular interventions overall by 24%, and all the outcomes put together by 24%. And all these were very impressively significant with the rivaroxaban low dose and aspirin. And just highlighting these as graphs here, the cumulative, primary efficacy outcome, the red is the aspirin alone, the blue is the rivaroxaban 5 BID, and the green one is the group with the low dose rivaroxaban and aspirin. You see in both the graphs here, the rivaroxaban with aspirin had the least incidence of primary outcome on the left and major adverse limb events on the right. So very positive data there. Been a few years, right, since COMPASS. And to be honest, this is a point for discussion later on, is that how much are we using Xarelto? Actually, what is the comfort level there? So major adverse limb events, as we know, worsens the risk of mortality and amputation overall. And, the graphs here below, this was a nice paper in JACC from 2018 that showed that before major adverse limb events, so the blue, the incidence, of death or vascular amputation compared to after major adverse limb events, you see the difference is that once they have an event, their risk goes up so much, considerably. And what's the rationale behind anticoagulation for PAD? So we now know, there's data out there that atherosclerosis is not just the fatty streak plaque and fibrous plaque. There is a thrombotic mechanism underlying atherosclerosis. And, there's been studies on PAD patients, and these are molecular level studies that have also shown that in addition to dysregulation of the anticoagulant, procoagulant, and fibrinolytic pathways, there are decreased levels of the naturally occurring protein C and S. There's more platelet activation, altered fibrinogen, thrombin generation, and fibrintomas. So they are hypercoagulable in some form, some way. And, if you're interested, there's ongoing studies out there on molecular mechanisms for thrombosis in PAD patients, which is why I think the rationale for the Xarelto and the improvement in the outcomes. And if you recall, Atlas TIMI was the initial study that showed, before in the acute coronary, within the 30-day period when they enrolled patients with low-dose Xarelto, in addition to dual antiplatelet therapy, that had led to better outcomes, which then led to the COMPASS study. So what happened after COMPASS? Last year, we had VOYAGER. So VOYAGER PAD was a trial where 6,500 patients with symptomatic lower extremity PAD undergoing peripheral revascularization, PAD defined as ABI less than 0.9, and imaging evidence of occlusive disease, aspirin on the background for everybody, and clopidogrel, depending on the investigator's discretion. They were 1:1 randomized to 2.5 BID of rivaroxaban or placebo. And the median follow-up was about 28 months. The primary endpoint was a 5-point composite of acute limb ischemia, major amputation, MI, stroke, CV death. TIMI major bleeding was their safety outcome. And you see here, the primary composite efficacy outcome, this Kaplan-Meier analysis here shows that rivaroxaban was significantly better and did show benefit in improvement in the group that received it overall over the median follow-up of 28 months. Now, there was a little small number of patients in the initial stages that had received clopidogrel, and those were believed those patients that had undergone revascularization. And so if you look at the primary endpoint, those patients here up here in the blue, those were the ones on the clopidogrel, and those were the black ones without clopidogrel. So what I'm trying to highlight on this slide is there was no heterogeneity between the endpoints, both the composite primary endpoint as well as the individual parts of the primary endpoint in terms of with or without clopidogrel. So rivaroxaban was beneficial both with and without clopidogrel almost equally. So there was not any significant difference in classifying them by the clopidogrel usage. But when we look at the safety end points here, there was no significant difference in TIMI major bleeding, which was the primary safety endpoint. However, if you look at the secondary safety outcome of ISTH major bleeding, it was pretty significant here in the rivaroxaban group as opposed to the placebo group. And when you go into details of reading this paper, this was mainly driven by those patients that were taking the clopidogrel that drove that ISTH major bleeding, just to keep in mind. And then we have another ongoing trial called AGRIPPA, where patients are being randomized within 72 hours of infrapopliteal angioplasty intervention to apixaban and aspirin and clopidogrel plus aspirin with a follow-up period of 12 months. So I'm hoping that at some point we'll get the results of that and we'll know. And this is going to be important because infrapopliteal is probably more prone to restenosis and occlusion. So and we're using apixaban here, which to me is exciting because if you recall, they had another study called EAT-PAD, where they used edoxaban following FEMPOP interventions. And this was a small group of, I think, some 100 patients that were randomized to edoxaban plus aspirin and clopidogrel plus aspirin. And it did not actually, even though, there was some benefit, I have the results right here. Early post-procedural period, there was a benefit of, but overall the trial was not that positive. So I'm hoping that the apixaban with the higher number of patients and intrapopliteal, we see some, results there because I think in the general practice, a lot of providers do favor apixaban over Xarelto for some reason in terms of the bleeding risk. So how should we all, put this together? And these are my last 2-3 slides here. So basically, this is a great paper from University of Colorado, and they looked at 393,000 patients who underwent intervention for revascularization for PAD, and up to 6 years from revascularization. If you look at the event rates there, the cumulative incidence, in the acute phase, there is like a rapid rise of a peripheral arterial disease-related limb events. The MI and stroke risk goes up steadily, but the vascular risk, goes up rapidly in the first couple of years post-revascularization and then becomes a little more steady. But as we said, once they have that major adverse limb event, the risk of death and amputation goes up significantly. So what would you do? And this is a really nice paper I found in Circulation from 2020. They have a really nice way to think about this, and I wanted to share this with you. So how would you go about antithrombotic therapy going for, in your PAD patients? So I think this is useful because in the acute setting, you're obviously going to have them on dual antiplatelet therapy. And then when you think of low-dose rivaroxaban, once they finish the clopidogrel for the short duration, I think rivaroxaban has good data out there to continue after the dual antiplatelet is done, or even start triple therapy first and then continue the rivaroxaban low dose with aspirin low dose and drop the clopidogrel. And for secondary prevention for chronic disease, it basically is based on the bleeding risk assessment. If you have a high risk bleeder, you're probably going to keep him on monotherapy. If you have somebody on low risk of bleeding, you're going to see what do they have a more risk of, MACE or limb events. And if they are at a higher risk of MACE, based on the COMPASS trial, low dose rivaroxaban is going to be recommended. And even for those with high risk of male, the low dose rivaroxaban is going to be recommended. For those at lower risk of MACE or male, then you're probably going to want to talk with them, and this is going to be your individual decision, whether you put them on DAPT, like dual antiplatelet, or just single antiplatelet, depending on their bleeding risk. So in summary, I would say atherosclerosis is a polyvascular disease, and PAD screening and medical management still remains underutilized, especially the screening. I see it in my own practice, and don't have a lot of providers ordering ABI screening purposes, especially in the medicine world. And newer data need to be included to provide a guidance document for clinicians. And I heard the latest is that the new guidelines are going to come out soon. So I would definitely, I'm excited to hear your thoughts about how your practice is in terms of the dual antiplatelet. How often are you using rivaroxaban, and are you comfortable using anticoagulation by now in your patients?
I'll speak up. One is, I was going to ask you this at the end of the talk. I think all cardiovascular practices see a lot of patients that end up being put on clopidogrel for an indication such as a stent, and they're not taking off the clopidogrel. There's some thought process. If you go back to the CURE trial and the CHANCE trial, the Plavix people used to tote that it decreased morbidity, mortality, but they used triple endpoints, and it was all driven by peripheral vascular disease, is what I remember. But some cardiologists continue clopidogrel for a long period of time, and I'm asking you, that's a large group of patients. It seems to me that we need to look at those patients. We take them off a lot. Maybe we should. You're saying if they have peripheral vascular disease, that we should be considering a 10A Xarelto or rivaroxaban, excuse me, in that group of patients. Is that, am I interpreting that correctly? That they would benefit?
Yeah, you are interpreting that correctly. So basically, when I looked at, and I know the DAPT paper, that had come out that looked at dual antiplatelet therapy, I think it was back in 15 or 16, if I'm not mistaken, or 14 or something. And then we had the COMPASS data. So the COMPASS data was pretty good because it did include stable coronary artery disease patients who were having, prior diagnosis of MI. But I see your point, and there's something that drives the good old practice of dual antiplatelet, and then they don't want to put them on rivaroxaban because they're just comfortable. If they're tolerating it well, not bleeding. I completely agree with you. There's still, the comfort zone is not yet reached for practitioners to prescribe Xarelto. We're not there yet, and I can tell you the inside story, even within Mayo Clinic. I trained there, and there was talk about putting patients on it, but how many actually are doing it? How many are actually putting their patients on rivaroxaban? So it's not there yet. We're not there yet. I still think there's like a few more years until providers get comfortable to do this, because they're always going to be worried about bleeding risk with rivaroxaban, no matter what you say, because it's an anticoagulant, it's a different mechanism action. But I think that the few patients that I have seen on 2.5 BID and the aspirin, and these were actually geriatric level patients, like 70s, they've actually tolerated that regimen pretty well. And so those were patients that had prior stents in the femoral arteries and required re-angioplasties and re-intervention. So I think gauging by the fact that how many times has this patient come back for a procedure or an intervention would at least make me comfortable to prescribe the Riva based on the data of COMPASS and Voyager, as opposed to if they're stable and they're not having any, limb events on the dual antiplatelet, why would I rock the boat? I agree with you on that.
Right. And just a point of clarification, rivaroxaban at 2.5 doesn't need to be taken with food for absorption as compared to the 20 milligram dose. Isn't that correct? Is that correct?
It needs to be taken with food. No.
Okay, that's what I thought.
This is Tabit Al-Sheikh again. I would just wonder if, I'm not sure if Luther or Safwan, our interventional cardiologist, with us, just to see how often they end up using the low-dose rivaroxaban in patients with PAD and intervention and difficult symptoms.
Yeah, I mean, I'd be interested in knowing, you know, how often do cardiologists use them? At least as I said, I see that the practice is still needs a lot more months before people will start using it. So how about yourself, Dr. Al-Sheikh? Do you use it in your practice?
No, I'm an EP. You just referred to my guys. I use it a lot for AFib. So yeah, actually, I never prescribed it at that dose. But to be honest with you, I haven't seen you know, I've seen a lot of articles in the JACC actually just last week or 2 weeks ago about rivaroxaban. So a lot of data as one of the DOACs for peripheral arterial disease that I haven't seen much data to support the other three in the market. So yeah, I have not myself prescribed it, but if I see it, I continue with it. That's why I was interested in our interventional cardiologist opinion. Well, probably they are not with us. I just have a question for you. Basically, you point out about the low-dose rivaroxaban in those tough patients, and you mentioned that specific patient LDL just a little bit below 70. Yeah. What do you think of pushing that LDL a little bit below 50, like some data and some guidelines, European data and guidelines, like we see with CAD and high-risk patients? And do you see any benefit of also checking for other markers such as ApoB or LP, little a, you know, all these things? Every time I read an article, they say, watch for other things. Do you go that far? Do you push that hard for PAD as you do for CAD?
So that's a great question. And I will tell you that I have actually started using lipoprotein A much more often than, you know, just the people with family history. Like I use it as a risk marker, even in those without a family history, because there's more and more data emerging for lipoprotein A. And as you know, the mechanism of, you know, risk with lipoprotein A is a thrombotic mechanism as opposed to the atherosclerotic. So to me, an elevation of lipoprotein A, and we're still learning more about this, it's not used as a target for treatment in these patients, but it is like a ticking time bomb out there, like, okay, lipoprotein A is elevated, it's a high risk. So those patients that have an elevated lipoprotein A, where the LDL is below 70, the interesting thing is, some cardiologists are driving it even lower if they're on maximally tolerated statin therapy and Zetia, and they're like, you know, 80 or 70 or something, because the lipoprotein A level is elevated. The other day I saw a patient who was actually prescribed PCSK9 because it's known to lower lipoprotein A levels. And it is a difficult conversation to have with these patients because they're all psyched up about their lipoprotein A level, their ongoing risk. And I think we need more data on this, because if it is a thrombotic mechanism of action, and if PCSK9 lowers lipoprotein A and we're driving the LDL down further, and the lipoprotein A is coming down with PCSK9 therapy, then does anticoagulation or anti-10A have a role to play? Because lipoprotein A is mainly thrombotic, you know. So I do check, the answer to your question, I do check lipoprotein and ApoBs very often in my polyvascular patients and PAD patients, yes. And I do, my first approach is always maximally tolerated statin and Zetia for them, an antiplatelet, aspirin. And then if they're not at goal, then I do definitely drive them below 70. Those that are already below 70, I'm not there yet. I'm like not going to drive them down even further, because I'm still learning myself, and I'm trying to figure out how do you actually deal with these patients that have an LDL at goal but have an elevated lipoprotein A. I mean, would I drive them down further? I don't feel that comfortable yet.
Okay. And how about if you get it 73 or 75? Are you okay? This is close enough, or you also push literally below 70?
Close enough, and then I talk to them about, how is your diet? Because half the time they're like, they think they're on a statin and their lifestyle is suboptimal. So I try to work with them, on their lifestyle and try to get them back in 3 months, see where they are in terms of their LDL. But that patient who's above 70, if he has an elevated lipoprotein A, I will probably consult with one of my colleagues in the lipid clinic and say, listen, should we be doing PCSK9 on this gentleman because of the elevated lipoprotein A? Because that's the only therapy that has shown to lower lipoprotein A in addition to, other injectables, and niacin. But niacin nobody uses to lower lipoprotein A because of the side effects. But statins don't lower it. Zeria doesn't, nothing else lowers lipoprotein A. So it'll be interesting to know if these patients, are the category that we should do antithrombotics in.
If I could add, in fact, statins paradoxically will increase lipoprotein A. And I'm sure you know this, but there's 2 trials going on right now with antisense oligonucleotides. And those are going to be coming out in 23 and 24. And I'm hoping that's going to answer the question.
Right. Mayo, Florida is not enrolled in it, but I know Cleveland Clinic had a couple of patients and we looked it up, and Cleveland Clinic's involved, and we sent a couple of patients there. So yeah, I think that would be interesting data out there.
Wonderful. In the interest of time, any other questions or comments? Perfect. Thank you so much. Now we're going to take advantage of you next time for the lipidology part.
Yes.
We appreciate your time, and thanks everybody for participation, and have a wonderful day.
Thank you. Thank you for listening. Thank you, everyone. Have a good day. Bye-bye.